Okay, let's start with, let's just go from the bottom here. The clinical context here, or the presentation really starts in February, which I do not have, but this radiograph is pretty much representative of the pulmonary findings I did see on a February chest radiograph. So we have multifocal, multilobar nodules, and some of them are cavitated. Perhaps this one is maybe one here. And certainly in the context of an infectious process and drug abuse, one would think of septic embolism. And then at this point, might as well put up the history, because she was diagnosed with MSSA. She left AMA, so not a complete success in terms of management. Treated with oral antibiotics and then presented with more symptoms. So more recently, looking at the lung windows here from February, there are multifocal, multinodular opacities, cavitation, certainly consistent with septic embolism, a rather large opacity there in the central lower lobe, but going to the mediastinal window, there are dramatic findings in relation to the pulmonary vessels. So I'll make that big. And I'll just give you a feel, it's a quick look through at the pulmonary vessels and how much abnormality is related to them. And the question might come up, how much of the abnormality is in the lumen? How much is adjacent to the lumen? Is it combinations thereof? And this was read as in part pulmonary embolism, but I actually think that, and I'll show you a coronal in a moment, that there probably isn't any bland separate pulmonary embolism. And I can tell you that in proximity to this, she had a venous ultrasound which did not show DVT. So let me bring up the coronal mix, which I think really nicely shows findings of mycotic aneurysms in many locations. And this coronal mix will show in multiple locations findings like this, where there are abnormal contours related to vessels, in particular abnormal dilatations. So let me find you a couple more like that, where the vessels suddenly get very big. So for example, here in the middle lobe, abnormal vessel, a bulge, that bulge, and there are quite a few of those in different locations. Let me find at least one more big one, like this one right here. So we have a lot of vascular abnormality, and I think in terms of your definition of pseudoaneurysm, if you require that even the adventitia be disrupted, well, this isn't that, but I imagine that people will use pseudoaneurysm to describe this, where you have maybe a paper-thin adventitia, but very abnormal vessels. And to go back to the axial CT, I think that we have findings of vegetations in the tricuspid valve. The more I looked at the valve and the surround, I think there are large vegetations there. And she did have large vegetations and even increasing vegetations in relation to the tricuspid valve, most recently just 2 days ago. So septic embolism, tricuspid valve involvement, but with multiple mycotic aneurysms, abnormal tissue, but I don't think any of these represent bland embolism. Anyone have any other thoughts about that, or are happy with the diagnosis of mycotic aneurysms?
I agree with
presumably impacted vegetations and complications of impacted vegetations and infection and cavitation and all the above.
No, I agree with you, Howard, and that's a very impressive case.
Yeah, it is. So obviously the surgeons are reluctant to operate on this patient, but I think they'll probably find someone and do so, because there's a persistent and progressive problem.
Can you show the lung
right
windows
there
again? Because one of the things
Okay.
sometimes I found helpful is distinguishing a bland infarct. And those look more like actual microabscesses, but just a bland infarct from a septic infarct is many septic infarcts often have a halo around them because of the just inflammation and maybe some hemorrhage, whereas your bland infarcts tend to be tightly marginated, at least when we see them. But in that anterior middle lower lobe right there, it's sort of fuzzy looking.
Yeah, there could be vascular occlusion and a true infarct there for sure in that particular location. But a very dramatic case, though. Okay, let me go to the next one. Now, this one is labeled in my comments vascular, but it's not necessarily so. So this is from the outside. This goes back to March when the patient has left pleural fluid, but of course, in addition to that, there is a very large solid mass in that basal hemithorax. And the question is, where exactly is it located? It's obviously contiguous with structures like the aorta and the vertebral body. And I think that at around about here, I think the mass is lifting up the crus in part and maybe growing primarily in the para-aortic retrocrural space. But obviously it's very large and occupying a substantial volume in that basal hemithorax. When we look at the SAG fuse, just to give you an idea of its FDG avidity, so a very aggressive looking lesion in that location. And ultimately it was biopsied successfully via a transesophageal approach. So obviously went in somewhere here and did a biopsy of this mass. And this turns out to be a high-grade smooth muscle tumor. I don't know exactly where it's arising, but it is a leiomyosarcoma with pathologic findings very consistent with that in that location. Perhaps arising from the crus, or maybe just, who knows where it's arising from precisely. But does everyone agree that it seems to be growing primarily maybe para-aortic, not that it matters that much, but para-aortic, maybe retrocrural space, and just being very large?
Yeah, that's a tough one. The center of it seems to be maybe pleural, but
it does seem to be biggest here. It's true.
Yeah, because there's only a little. I would expect if it started in the mediastinum, it would have pushed the aorta over more, unless it gained entry into the pleural space early on and was able to just follow the path of least resistance. But I don't. Yeah, it doesn't really matter.
Yeah, it doesn't really matter too much. I was trying to decide whether some of this is an elevated diaphragm or crus up here somewhere, but it is hard. All right. This is a patient with a history of lung transplantation about 5 months ago. And this one is a hard one because going back to a comparison in February, and it was a very complicated procedure. She was very ill, required a tracheostomy for some time, so had a rather stormy hospital course. And then going forward now to April, it's hard to know exactly what's going on in the lungs and the basal chest because there's so much abnormality. But clearly there's new disease, particularly on the right side, in April compared to February. She had quite a workup that involved a nuclear medicine scan, which involved a SPECT CT. So this is actually just a part of the SPECT CT nuclear medicine scan. But what you can see here is what was diagnosed in part, which was progressive narrowing of airways, particularly involving bronchus intermedius with associated atelectasis, involving portions of the right middle lobe and the right lower lobe with the expectant findings of abnormal ventilation and perfusion on that scan. And then I'm not entirely sure why, but a PET CT was done in May, and it showed a bunch of things. So let me make this a bit bigger. It showed a bone lesion. There was an abnormality described in relation to a segment of bowel down here, but then pretty impressive findings in the chest. So we have lots of nodules, largest in the left lower lobe, there's one in the right lower lobe. There are more nodules elsewhere, some in the periphery, subpleural. This is either a nodule or lymph node involvement. And eventually a CT guided biopsy was done of the left lower, one of the right lower lobe nodules. And indeed, this is PTLD. So this is a case of PTLD. The features are pretty consistent with that. Parenchymal disease, not sure about nodal disease. Disease outside of the chest, although they were not biopsied. This is a diffuse large B-cell lymphoma and a PTLD case. All right, let me show you the last one. The last one is a kind of one of these mundane things. You get a history of a patient that had a ground level fall, and one diagnoses rib fractures and keep on looking because there's one finding that shouldn't be there. It's rather subtle. There is an abnormal opacity in an interface that one doesn't expect with a ground level trauma.
Is there something subcarinal?
Here?
Yep.
Yep, exactly right. So right here is the abnormal mediastinal lung interface. It's in that location with associated opacity. And certainly I don't associate that with trauma. Usually if you have vertebral body fractures, which may be hard to see, usually the paraspinal hematoma doesn't produce something that looks rounded or doesn't produce a focal, doesn't usually produce a focally convex interface like that usually. So that turns out to be this. It's anterior. There's the interface that we're seeing right here. There is the rest of it. And this, in my view, is very typical for a thymoma. So the incidental, if you will, discovery of very likely a thymoma in the context of trauma. Because of the person's age, and I think quite recently, the patient has declined further evaluation, is 80 years of age, and the likelihood that this will hurt him in his lifetime is pretty low, but very consistent with a thymoma. Yeah. I think in the context of screening, one diagnoses thymomas around 5% of the time as an incidental finding. Usually they're small, of course, but not surprising, really.
My experience is we find them more often when we're not looking for them than when we are. I don't know if that's been yours.
Yeah, it's kind of hypervascular too. If it were a younger patient, you might think that it could be a paraganglioma. You know, but
it's vascular, not super paraganglioma-like, but it is enhancing somewhat heterogeneously. Yeah. Yeah, it is. But I think just follow up in an 80-year-old person is reasonable. He's been living with that blood lupus for quite some time, of course. All right, Jeff, those are mine.
All right, thank you, Howard. Who'd like to go next?
I could show some if you want.
Sure, always want.
Hold on one second. I just gotta pull them up. Oops, 1 second. Close my pack so we can see what I'm showing. Here we go. Which case is this? Which case this is? So let's see. Oh, this is one of my more favorite cases I've seen in the last few while, I'll say. So this was a young girl who had chest pain and came in with small little pneumo, and then these kind of masses here on the pleural space. And then looking at her history, which was actually a surprisingly good history, from a note, the note just, I mean, the indication she had chest pain, but in a note they said that she had severe chest pain with the onset of menses. And then further on in her other notes, they described that she had stage 4 endometriosis with peritoneal implants, which I don't see here, as well as infertility and other issues due to endometriosis. So this is a catamenial pneumothorax with endometrial implants, or at least presumed. I haven't seen one of these in a while. De novo.
Usually the implants are below the resolution of CT. That's impressive.
Yeah, exactly. I've never seen them that large.
Well, I mean, we said to definitely go for a biopsy, or at least, you know, someone put a scope in there and look. You know, initially I was wondering, is this some sort of hepatic herniation? But there are just a lot of them, and it just didn't make sense. So
yeah, you're almost certainly right. Yeah, it's just really impressive because it's on the right side. The history fits.
Yeah, and she has. Yeah, and she's had biopsy. So she came in for an appendectomy many years, like a year ago, and she had appendicitis, but they noticed these nodules in her belly, and they, you know, biopsied them, and it was endometriosis. You know, they described like macroscopic, decent sized nodules in studying the peritoneum. They thought she had peritoneal carcinomatosis from an appendiceal tumor, but it was all endometriosis, and she had, you know, other issues. So hopefully they'll get some tissue to confirm the diagnosis. I haven't seen a case of that in a long, long time.
But I have seen macroscopic ones before, not as big as this, but say centimeter sized nodules before in this with this diagnosis. So they can be visible on CT scans.
Yep.
Yeah. This was just something I haven't seen in a while. And I didn't, it just also shows the importance of, I mean, we all miss stuff. I understand that. And especially when you're outside your specialty, and especially if you're outside your specialty reading a belly film. So this patient has had a couple abdominal CTs over the years. And, you know, no real comments made on the pulmonary hypertension or the big PAs at the bases and some scarring. But and she was being treated as PAH. Well, technically now this is technically considered type 1 disease. It's been changed, but, you know, truly idiopathic PAH. And, you know, and then she was worked up for CTEPH, which of course was negative. That was the reason for this CT, was for CTEPH. And then we, you know, whenever you see, like I tell, if you ever see a massive right heart and sinus pulmonary hypertension, you know, and it's, just try to find a shunt or look for a shunt. You can see here that the IVC, let me reset this, actually instead of comes up, and instead of clearly draining into the right atrium, part of it goes to the right atrium, but the majority of the flow goes into the left atrium. So this is an inferior sinus venosus. Interestingly, it's not associated with a, in this case, it's not associated with a PAPVR. I've seen a few inferior sinus venosus not have PAPVRs. All of the more typical superior sinus venosus, everyone I've ever seen has had a PAPVR. I've never seen one without, with the right superior pulmonary vein coming into the SVC. Now, what's interesting about her and why she probably presented so late-ish in life is that she also has, I should have sent over, she also has azygos continuation of the IVC. I have some delayed studies going down a little bit lower, where you can see she has this huge azygos vein that then drains into the SVC. So she's kind of lucky in that respect, because the majority of her, you know, everything below the everything from the renal veins and below are pretty much draining via the azygos system, which is not really shunting, because that's going normally into the right atrium. So it's just interesting case. I haven't seen a lot of inferior sinus venosus, and yeah, and she has awful pulmonary hypertension. And the other thing I want to mention, which is really interesting, which I've seen now, is that this really well-defined geographic pattern of mosaicism, kind of that CTEPH-ish look, if not, to put a better word to it, is I've only really seen in two things. And one is CTEPH, when it's truly vascular in etiology, and the other is long-standing shunts. And I don't know why, but I have about 10 cases of long-standing undetected shunts, right to left or left to right, that lead to this pattern of mosaicism. You would think it would lead to the typical kind of PAH or other causes, but it doesn't. Why that is, I don't know. But anyways.
Well, so Seth, is it shunt with with pulmonary hypertension, or is it just shunt that does it? It's
in this case, it's going to be the shunt. I would imagine.
But this person has pulmonary hypertension, right?
Oh yeah. But I think it's it's pulmonary hypertension due to the long-standing shunt. So I think it's congenital. It's type 1 where there's congenital heart disease.
Got it.
Leading to long-standing pulmonary hypertension.
Okay.
Because yeah, it'd be interesting to know how much of the blood, what person, and we're gonna have to work her up. It'd be interesting to know over the years. Originally she had to be a left to right shunt for a long time, and then question is, now that she's probably has Eisenmenger and going right to left, and now you have all that right-sided blood shooting into the systemic circulation. Is she, is she better off for that or not? And the answer is I don't know. And this is an interesting case just to get people's impression on. So this is a guy who was COVID positive, was admitted for COVID a while back, well over a couple of months ago. Not a couple of months, but early on, kind of early March, and recovered, and then came back to the hospital and was not feeling well and was quickly intubated. And they showed me this, and I said, it just looks like pneumonia to me. I don't know what to tell you. It doesn't look like COVID. It just looks like some sort of pneumonia. So he wasn't getting better. They were treating with wide spectrum antibiotics, and he wasn't getting better. And they did a bronchoscopic biopsy, and it came back as lipoid pneumonia. Now, the interesting thing about it is that it's not vaping induced lipoid pneumonia. He's a police officer. He has no history of vaping, or at least he says he has no history of vaping. But he did supposedly, after he was discharged from the hospital, him and his wife were spreading, according to the notes, were spreading Vicks Vapor Rub all over him because he was having trouble sleeping. And he was having issues with breathing at night because of, I guess he was intubated or had some issues with difficulty breathing at night because of his post-COVID. Who knows what happens post-COVID in terms of there's small airway issue or just from being sick for so long. But the question is, has anyone seen, and they said, from the report, they're like, it could be endogenous lipoid pneumonia, it could be exogenous lipoid pneumonia. Has anyone seen lipoid pneumonia this extensive and upper lobe predominant?
The first question, that extensive, no. Makes you wonder, there was no superimposed infection, like a mycobacterial or nocardia or something that the patients with lipoid they're predisposed to?
They did a full infectious workup for what that's worth, and everything came back negative. Yeah, I don't know. To me, it's a little suspect as well. I don't know what to say.
Yeah, it looks like there's more superimposed lung injury. I mean, I have a case of lipoid pneumonia from, I think we may have seen it on the webinar, or someone showed one, but I think I have one too, of a mild lipoid pneumonia from someone who put it in their nostrils, but it was never that extensive.
Yeah, it just doesn't make, I mean, I've seen it with Vicks and it's been mild, It's been dependent. you know, like if it was just the dependent stuff, I'd be like, yeah, okay. But it just doesn't make sense to me.
Yeah, I mean, that's really dense consolidation in those upper lungs.
Yeah, and the interesting thing is, I'm showing the second one. So he wasn't getting better with anything, and then they started him on steroids. And this is what he is, you know, a few days after starting a steroid, so dramatically improved. So I don't know.
Treating some organizing pneumonia.
Yeah, exactly. Something's treating something that's some organizing pneumonia, but that was a weird case. I agree. Someone told me that, and I was like, I never seen it look like that, but.
So, I mean, there are lots of ingredients in Vicks Vapor Rub, I think. I mean, isn't there eucalyptol and some, you know, methyl salicylate or something like that? I mean, there's a whole bunch of stuff in there, and it could be that there was a reaction to those compounds, not just the lipid component, but all those aromatics that they put in it too.
Maybe, yeah. And then also very nicely, a sign that I'm commonly seeing with organizing pneumonia now is this sparing of the peribronchovascular interstitium when it starts to kind of recover. You know, we've seen this in some of our EVALI patients. Anyways, those are my cases.
Yeah, that's interesting.
All right.
I've got a couple, Jeff.
All right. Let's go to David.
So I hope people can see this chest radiograph here with diffuse lung disease with a ill-defined nodular component to it.
We do.
And this is multiple drug-resistant tuberculosis in an African patient. I haven't looked up the history in detail. And because people don't trust radiographs, they want CT scans. I'll show you a CT so that you'll believe that the lungs are diseased here. So this is a miliary pattern that, you know, it's really nodules everywhere, and they're confluent. This is the resolution of this CT scan. Plus, there's some basal consolidation as well and some pleural effusion. I think ultimately there was some renal failure, and the person got a dialysis catheter placed. So really florid tuberculosis. And now we have about 6 weeks of imaging on this person, and the lungs are still, you know, just diffusely involved with more and more basal consolidation. So bad case of miliary TB.
Wow.
And then this is a person who has this ancient radiograph from 2008, and it does show this subtle mediastinal convexity down here. And the lateral shows, you know, maybe some fullness anteriorly there. It's a little hard to evaluate it up at this higher level. This is a fairly young patient. And, you know, the heart looks kind of big here for a young patient, but I think actually a lot of this is not really heart, it turns out. So around this time, there was a CT scan, and it shows that there's this low attenuation mediastinal mass. So I measured some density of this stuff, and it's about 18 Hounsfield units. So it's pretty low, but it's not fat. It's not a liposarcoma. It's this big, you know, fluid-filled thing with some inhomogeneity in it, but, you know, mostly just looks like liquid. So this was resected. This was called a multiloculated thymic cyst. And then after the surgery, this is a few weeks after recovery. Let's see, at this point now, he's got sternotomy wires. Does have a pleural issue over here, some anterior stuff here, but the mediastinal mass component has decreased. Heart doesn't look as big as before because some of that was really the mediastinal tissue. So this takes us to 2009. And then more current imaging now shows a new mediastinal convexity down in this location. It's looking kind of like a pericardial cyst in that location. And on lateral, you can see that it's anterior and basal. And this was re-CT'd, and we seem to have recurrence of anterior mediastinal low attenuation material, and then this big component over here in that right cardiophrenic angle. But it's all contiguous, with this anterior mediastinal tissue. And there's also stuff back here now in the more posterior parts of the mediastinum. There's sort of similar lowish attenuation in homogeneous stuff. So this is thought to be a recurrence of his thymic lesion, which was a multiloculated cyst. Now they looked very carefully for any malignancy, and there was no evidence of malignancy. And I did read that, I pulled up an article that said that acquired mediastinal multiloculated cysts can recur after resection. So I guess what happens is that there's some tissue gets left behind, and that's enough to generate this process all over again. There must be some genetic or abnormality that causes cysts to form out of thymic tissue, and perhaps residual tissue can continue to do that. It's not really a malignancy. It's not. This was not a thymic carcinoma, or a cystic carcinoma of the thymus, but it is some sort of developmental problem probably that can recur. So I don't know if you guys have seen very many multiloculated thymic cysts, and whether anybody else has a case of recurrence 10 years out.
We have one that recurred. Initially, I thought it was going to be like a lymphangioma or something, and those also recur.
Yeah, right. It was not.
I do have one case that was called a thymic cyst, and that it did recur many years later. But yeah, I was pretty sure it'd be a lymphangioma when you first showed it.
Yeah.
David, can you show the first CT? Because I wondered whether in a couple of places it wasn't completely cystic, whether there was any tissue,
right,
vessels in its anterior portion on one of the CTs that you showed.
Yeah, this is the earlier CT, and it does have some inhomogeneity to it. I mean, I thought up here there were some denser elements up here. It was not uniformly low attenuation.
So it's possible perhaps that it really is a cystic thymoma, rather than a cystic lesion, a cystic thymoma that has recurred, where the thymoma is primarily cystic, but not completely so.
Well, that's what I was suspecting too. So I asked the pathologist to re-review it, and they looked at that possibility very carefully, and they believed that this was not a cystic thymoma.
I have to say, most cystic thymomas actually have a kind of more of a mass. It's just a cystic mass. I mean, that looks like it's just fluid and thymic tissue draping over the mediastinum. I don't know.
That's really peculiar.
Okay, and it has not been re-examined pathologically. So I view this as most likely a recurrence because it's a similar look, and it's adjacent to where there was an abnormality that looked the same before.
Yeah.
But we don't have a lot of intervening imaging to show a steady progression, and we don't have new pathology. But we'd have to invoke a second process to explain this new lesion if it's not just a recurrence. Okay, guys, that's what I wanted to show.
Okay, thank you, David.
Thank you.
All right, I can quickly show some and then we'll go on. Let's see. Okay, let's start with this one. So this, how old the patient is, but middle-aged patient, has chronic disease, and a couple things on the radiograph. You can see some ill-defined nodules here. They look pretty dense, so they may be calcified, but I want to draw your attention to the trachea, and it's quite narrowed towards just above the thoracic inlet here. So, and it's narrowing the trachea, maybe a little bit of wall thickening there. Here's a CT scan done, and what we see on the CT is quite a bit of wall thickening and narrowing. So we're just above the thoracic inlet, and then as we go down, you'll see there's a little bit of mural regularity, and then relatively normal beyond that. And then the lung findings, you can see we have all of these nodules sort of clumped together. So when I see clustered nodules, I always think of perilymphatic distribution. And then we see a few subpleural nodules on the other side, but not a huge burden of nodules. So this patient, and then you see a couple other little ones, this patient carries a diagnosis of sarcoid. And so the nodules are all in keeping with that. But tracheal involvement, while it's described, is actually quite uncommon. You can recover non-caseating granulomata on biopsy, but we typically don't see. I've only seen one other case of marked.
That's really, I mean,
yeah, no,
that's really rare.
Yeah, and you can see this airway is on its way out here. They actually had to do emergent airway surgery, a tracheostomy to keep that open. I have some images of it.
She was never trached or anything, or had to end it well?
No. And I think if I can get the right sequence here, we can see down into the airway. But yeah, you can see it in there. It's normal. It's kind of nodular and very narrowed there. There it is. A lot of inflammation, all these blood vessels there, but just really tight. So this had been a chronic problem, the airway involvement. But it is in the differential for tracheal thickening. But again, it's a very, as Seth saying, very rare. This, and his question about the intubation is because it's sort of in the right location for it. The other thing you might think about is GPA, because it is in the subglottic trachea, which is a common location. But this is quite striking. So this is a sarcoid with tracheal involvement.
Jeff, did I also see the thyroid just?
Yeah, thyroid's really big,
enlarged, but yes, otherwise not related to that.
Is that as far as I know, yeah, it's just a goiter. It's just a goiter. That wouldn't explain the wall thickening. But yes, good point, Howard. This case, let's see. Yeah. So this is just a fun radiograph, especially if you're trying to figure out what's going on. So we see this individual has these embolization coils and then this funny tubular structure here on the left hemithorax. And if I go to the lateral, you can see these are in the area of the descending aorta. And then you have this tubular structure here. It's hard to see if I don't necessarily see a surgical defect over here, but we don't see sternal wires. But this patient has a long-standing history of aortic coarctation, and this is a treatment that's usually reserved for really resistant cases or complicated cases. So this patient has an extra-anatomic graft here. So on the CT, we see the conduit coming off the proximal descending aorta, and then it extends presumably in the extrapleural space. Although it's interesting how it interfaces like this, but there's fat coming up along it. So it extends along the posterior chest wall and then makes its way into the abdomen, where it then will anastomose. And you can see there's an aneurysm at the anastomosis there that's excluded it. And these patients with coarctation, often the aorta itself is abnormal. There's something wrong with the tissue. That's why they have high rates of recurrence. There's associated valvular disease. But what was interesting is she actually had presented to an outside hospital with some hemoptysis. And on the CT, there is this sort of nodular ground glass opacity and some a little bit abnormal airways right in the vicinity of this graft. And I tried to get the pictures, but they're not available because it was done elsewhere. But she did have a bronchoscopy, and apparently they saw blood down in this left lower lobe. And the concern was that this was communicating with the lung. There was sort of a fistula. I looked on the CT images and I really couldn't place it. So I don't know if it's a little tiny contained leak or if it's true and unrelated. You can see there's, there's already embolization down in this area too. There's big coils down there. So maybe at some point there was a communication, but I haven't seen too many of these grafts. I don't know if anyone else has. It's not a common treatment for coarct, but just made it for an interesting radiograph. And this is where they embolize the native aorta at that point. And then there's the aneurysm down there. Yeah, kind of crazy. Now this is a cool case, and this is something I remember reading about in residency and never seeing a case, and I've seen two. But so this guy has long-standing lung disease and farm exposure, and there's actually two things going on. So in the upper lobes, we can see there's bronchiectasis, there's mosaic attenuation. Quite bad bronchiectasis, and you see the mosaic attenuation. But down in the lower lobes, he started to develop some reticulation, and several years later. So the airway disease has been longstanding, I think, for better part of at least a decade, if not longer. But the fibrosis has just developed over the past few years, and they're probably both related to agricultural exposures, but he has a history of silo fillers lung disease, a nitric oxide exposure many years ago, and it initially causes an acute lung injury, and then patients that recover, which more and more would, but just with good support, they are often left with a chronic airways disease, including constrictive bronchiolitis, which can then lead to upstream phenomenon and bronchiectasis. So he's had this bronchiectasis for a long time, and the thought is this was all related to his silage exposure many years ago. But now he is becoming more short of breath, and over serial scans, he is developing more and more subpleural reticulation. And so I suspect the fibrosis is probably just from years of dust exposure, just being on a farm. But I don't know if anyone's ever seen silo fillers disease. It's pretty uncommon. You're more likely to see someone fall in a silo from too much beer than actually inhaling the stuff. I think David told me that one time.
Very far away from beer, is it? I mean, beer is a common pathway in your state, I think.
Yeah, well, we make a lot of it and consume a lot of it. But yeah, I just haven't seen a silo fillers in a really long time. And, even though there's a lot of in agriculture, I think it's because most people are very aware of it, that the gases and the silage can be quite damaging to the lung. But this showed really impressive airway findings. But so I don't know. I think the fibrosis is completely unrelated, and whether, as far as I know, he's a never smoker, so more likely to be related to just chronic dust exposures on a farm, and we see that not insignificantly.
Oh, curious case.
Yep. I'll just put up the corona real quickly so you can see the extent of the bronchiectasis. It's pretty impressive.
So, Jeff, my understanding of the silo fillers lung is it's not an immune mediated thing, but it is actually a chemical burn in the lungs because there are nitrogen oxides that, when they react with water, turn into nitrous acid or nitric acid, both of which burn the lungs. So it's really a chemical burn.
Right. Yeah, and it's with these gases, like a lot of it has to do with the solubility, and like chlorine, for example, tends to cause more central injuries because it's fairly soluble and gets the upper aerodigestive tract and the mucosa of the central airway. Some of these other gases, hydrogen sulfide, for example, is, I think, if I remember, is less soluble and tends to cause smaller airway involvement. Same with nitric oxide. So there's something called dung lung, which is from pig manure gas, hydrogen sulfide, the rotten egg smell that can also cause small airways involvement. Yeah, there was a really old radiographics paper by Judd Gurney called Agricultural Lung Disease. It's a great one. It's a really old PDF, but it goes over a lot of these. Okay, who'd like to go next? Peter, do you have cases?
Yeah, I have a few, Jeff.
All right, I'll make you the presenter.
Okay, so this is a 70-year-old patient with a long history of Sjogren's syndrome, and just showed 2 CTs of hers. Yeah, the first one is this one on the right side is from more than 10 years ago, from 2009. And then the one on the left is from 2 days ago. And just kind of highlights some of the typical manifestations of Sjogren's intrathoracic. So we have these thin-walled cysts. They look very bronchovascular. So one would think of LIP, and then a lot of them have these nodular calcifications.
Or ossification, actually.
Ossification, right?
Yeah, that's part of the amyloid component.
Right. So this is suggestive of amyloid deposition here, and just comparing over the last 10 years, I was surprised how there hasn't been a whole lot of change. Some of them have progressed. For example, this one right here, but many of them are not significantly changed. A little bit more cyst formation towards the bases here. But and then more amyloid, most likely amyloid here.
Yeah, it's a very nice demonstration of the amyloid in the sense that we have all the nodules with calcifications or ossifications, and many of them are, not surprisingly, in proximity to the cystic areas.
Mm-hmm.
So it's the protein that produces the cysts.
Yeah. Now, interestingly, she did have a transbronchial biopsy from a few days ago, and they weren't able to demonstrate any amyloid on the Congo red, but it might have just been a sampling error.
Right.
It was a transbronchial. They just saw some interstitial lymphocytic cells. Okay, so I'll show another one. This one was a quick one. So this is a coronary CTA, but the interesting finding is not in the coronary arteries. It's this abnormality here adjacent to the mitral valve apparatus, and it kind of has this look of same density as the contrast. It looks almost like a cavity or a pseudo aneurysm, but you can see all this mitral annular calcification around it here. And then so the diagnosis becomes more clear if you take a look at the unfortunately my Osiris froze. Oh, or I
maybe it's just one image.
No, actually I actually uploaded the wrong image, but maybe I can pull that up later. But this actually on the non-contrast was actually calcification, all this, and it just happens to be the same density as the contrast. So this is caseous mitral annular calcification.
Yeah, nice example of that. Yeah.
So often on echo, mistaken for a mass or for a abscess, but it's just a benign variant of mitral calcification, annular calcification. And I'll try to send out the non-con showing it. And this is another case I recently ran into. This is a 70-year-old patient, and she has a history of, you can see here, a VSD, so unrepaired VSD. And the thing that stands out here is this profound hypertrophy of her RV wall. It looks thicker than the LV. So she has Eisenmenger's syndrome, and she has a few other interesting associated findings. So if we go to the PA, she has filling defects. You can see atherosclerotic disease along the intima of the PA. Filling defects. This is in situ thrombus, most likely, which is commonly seen with Eisenmenger's. And then if we go a little bit more peripherally, you can see these serpiginous vessels, which are pulmonary arteries, arterioles or arteries distally, almost continuous, almost running into the chest wall. This has been described as neovascularity, and then also other interesting stuff is she has these prominent chest wall collaterals, and in some regions it looks like they're communicating with the pulmonary vasculature here. This collateralization. She also has a lot of collaterals in the or a lot of bronchial artery collateralization here. This was actually done for hemoptysis, and you can see some. I'm presuming that these opacities up here, which were new compared to the prior, are hemoptysis, and you can see the large vessels. coming in there, probably bronchial artery collateralization. I think we've referenced this article previously, but this kind of describes some of the findings we've seen here. This article from 2005, where they describe this term of peripheral neovascularity, and they describe these tiny micronodules, which on my scan are difficult to see just because the resolution wasn't a great scan. And they also describe the collateral vessels, the chest wall collaterals, which are communicating with the pulmonary vasculature. And they kind of talk about how they think these neovascularities separate from the plexogenic arteriopathy. I'm not sure if that's been confirmed. And that's all I have.
Yeah, very impressive amount of disease.
All right, thanks.
Thank you.
Excellent cases. If there's any, I think Travis, yeah, he was unable to show cases today. So unless there's anyone else, I think we'll just finish a few minutes early. All right. Well,
Thank you, everyone.
Yeah, talk to you next week.
Later.
Bye.
Bye, Seth.